When she gets here. So we can start with the meeting minutes from the February meeting. Did anyone not have an opportunity to review those? Okay, do I have a motion to accept the meeting minutes as written?
Second.
Second motion? Okay, the meeting minutes will be accepted as written. A brief update. I know last time I gave you guys the brief update that the pretrial risk assessment tool was, we had a vendor on board and we were just kind of finalizing things. So the vendor we do have is JFA Institute, which is actually the same vendor that created our previous tool, but come to find out it's very outdated. So we're working with them now. They're officially on board and we've started that process. We're actually meeting with the judges this week to get their input, and it's full steam ahead. So because of this group, we're hopefully going to have a success out of the new pretrial risk assessment tool. So we can go ahead and get started with our committee reports. Amy.
Good morning. I was in
Morning.
my 83 traffic stuck with you.
Awesome.
So we were sprinting. So good morning. DVCC will meet again on May 3rd. So we haven't met since this group has met. We are plugging along with conference planning. So we have secured the site and have put out the call for presenters. So September 20th is the big day, and we look forward to seeing you all at the conference. Thank you all for supporting us, not only in terms of staff to help us plan, but also some of you have put money to the table, so we're grateful.
Great, thank you. Anything for Amy? Hey, Tanya?
Good morning, everyone.
Good morning.
So our last meeting was held on March the 13th, and one of the highlights was that the mobile crisis team for Baltimore County, they have some additional services that they've been offering. And one of the things is a peer support team for the employees. So that's something that my colleague and I went to South Carolina last year to hear about. So hopefully we'll be working on that at the detention center in the very near future. And the only other thing is the ongoing issue with the offenders waiting to go to hospitals. We have like 29 people still awaiting transfer to Maryland Department of Health Hospital.
And 5 of them are very acute. 5 of them.
5 of them, I'm sorry.
Very acute.
Acute. Anything on this update? Okay, so we'll get started on the presentations. For those of you that don't know, the topic for the next couple meetings will be substance abuse. So we just came off of mental health and we're going to enter substance abuse, but they might be intertwined. So it would be a good time to discuss that. So first up is Elise, and I think Elise and Amy are going to do.
Yeah, I'm just going to give
Okay.
a brief overview. As you can see up there. Well, first, good morning. I'm Elise Andrews. I'm the opioid strategy coordinator. I thought it might be helpful just to look at a little data and a little background around the epidemic so that we know, kind of what we're dealing with. This first chart just shows you unintentional drug and alcohol related intoxication crude death rates. So here you can see that Baltimore County since 2015 has been a little bit above the state of Maryland. In 2022, it looks like we dipped a little bit below. We're hoping that holds because this is still preliminary data, and the preliminary data for 2023 shows that we still may be a bit below on rates. Now, when you take this and compare it to nationally, nobody calculates the same rates the same way, so we can't, I didn't put the national rate on here because it's not exactly comparable, but it's around 35 per 100,000. So Maryland and Baltimore County have traditionally been above the national rates, but it's not exactly comparable. What these rates translate to is about, we can go back one, sorry. It's about 220 deaths in 2015 a high of 394 in 2020 and down to about 340 in 2022. And we don't have a final number yet for 2023. We thought there was going to be a decrease, but they added a bunch of cases just in the last couple months. So we're kind of anxiously waiting to get that data. So it's important to understand where the epidemic came from, and this chart shows you the 4 different waves of the epidemic. I'm not going to take you all the way back to the 1800s when cocaine and opioids were unregulated and used in cough syrup and there's cough syrup, soda, and teething remedies. But it's important to understand that that's kind of where this all started. Medical journals in the 1870s were describing the pitfalls of overprescribing. And the Bayer Company came out in 1898 and said, hey, guess what? We have something better than morphine. It's less addictive. It's heroin. So we have been here before. As a country, as a community, we've been through this before. But then OxyContin, thanks to Purdue Pharma, came about in 1996 amid relaxed regulations and pharmaceutical lobbying. And they used, and they admitted to this, deceptive marketing and aggressive overprescribing to address pain as the 5th vital sign. So in 2007, Purdue Pharma pled guilty to misleading the public about the addiction potential of OxyContin. And then you can see there's a slow decrease of prescriptions that then lead us to wave 2, which was the rise of heroin in 2010, followed closely by wave 3 and the rise of fentanyl in 2013, and then changing again in 2015 to include fentanyl and stimulants such as cocaine. So what's important about this graph is to understand that we're not dealing with a prescription or heroin epidemic anymore. We are dealing with a fentanyl and stimulant epidemic. And that has a lot of implications. For how we provide services and how we address people who are suffering from substance use disorder and opioid use disorder. Go to the next slide. So there's several schools of thought about where the epidemic came from or the root causes. Supply-driven, demand-driven, and probably the reality of it is that it's somewhere in between the two. So the supply-driven theory argues that the years of overprescribing increased demand, and then when prescriptions were more tightly controlled, individuals turned to heroin, with heroin then being replaced by fentanyl, which is now widely available in all of our drug markets and contaminates most illicit substances. The demand-driven theory traces the decrease in local economic opportunities and relates it to demand for drugs to relieve mental stress. So the connection between rises in unhelpful behavior and economic stress is proven in research when you look at recession, unemployment, and increases in illicit drug use. So when people are under stress, especially from economic situations, they turn to ways to deal with their pain, their mental pain, their emotional pain. And in this case, we're looking at opioids. The deaths of despair theory was put forth by 2 economists in 2015, where they were studying the rising death rates in the US. Connecting those death rates to the white male population with less than a college degree. This theory has been a little bit called into question because it's not as comprehensive when we look at different races and ethnicities, but there are parts of it that are relevant to Baltimore County. If you look at the deaths of despair theory, it focuses on loss of economic opportunity and specifically on manufacturing jobs. One complementary study that found a greater increase in opioid deaths per 100,000 working age people in the 5 years following an auto plant closure than areas with similar loss of economic opportunity. So anecdotally, if you look at our highest overdose burden areas, Essex, Dundalk, we know that we lost a GM plant there in 2005, and we also lost the Bethlehem Steel plant. That went from a large number of families that it could support and went down before it closed. It had lost 94% of employees. So in that area on the east side, you've had major economic changes over the last 20 to 30. So as we consider our lost economic opportunities and increased availability of lethal drug combinations, it's also important to understand factors at community, family, and individual level that increase risk or offer us protection. Risk factors obviously are associated with higher likelihood of negative outcomes. Protective factors are positive, either countering the risk factors or lower likelihood of negative outcomes. So at the individual level, some of the risk factors are genetics and exposure to substances in utero. At the family level, we have inadequate supervision, child abuse, low parental education, trauma, generational use of illicit substances, and lack of opportunity. At the community level, poverty, violence, and racism have all been shown to increase risk, as well as contributing to adverse childhood experiences, which also increase risk. So I would just ask you to look at this array of risk factors and think about children and adolescents, because that's when they form their habits and their attitudes about substance use. How many of these factors do children and adolescents control? Next slide. All right, looking at protective factors, the protective factors can influence attitudes and habits, from positive self-image and self-control at the individual level to parental involvement and housing stability, financial security at the family level, and community factors such as availability and engagement in extracurricular activities, existence of hate crime laws, all can serve to decrease or mediate the impact of the risk factors. So taken all together, the risk and protective factors are really kind of summed up by the social determinants of health, which are the conditions in the environment where people are born, live, learn, work, play, worship, and age. These all influence functioning and quality of life. And increasingly, they're finding that these factors have a greater influence on individual outcomes than individual health interventions. So just receiving treatment is less influential than what's going on in your environment, in your community. Next step. All right, so another issue considering social determinants of health, it's important to consider the impact of the war on drugs to conditions where people live, work, and age. From the laws all the way back to the Nixon administration in 1971, the Controlled Substances Act, to the Anti-Drug Abuse Act in 1986, which had significant racial impacts in that it greatly criminalized crack cocaine over powder cocaine, even though the actual intoxication effects were not borne out in the science. So you have people who are using crack cocaine being prosecuted much more heavily than people using powder cocaine. And we know from research that that translated to over prosecution of Black and brown individuals. The other piece of the war on drugs that we have to look at is enforcement, that nationwide drug offense is the leading cause of arrest. Black people are 13% of the population, they're 24% of the drug arrests, but research finds that people of all races use and sell drugs at similar rates. Another aspect of this is the drug war logic that permeates housing, employment, healthcare, education, and public benefits, where we've criminalized and stigmatized people who use drugs and influence their ability. If we go back then to thinking about social determinants of health, how are people supposed to thrive in their communities when they have records that prevent them from getting housing, getting employment? They're stigmatized in their healthcare settings, they don't have an education, and they're kept out of public benefits. So where does this leave us? The most recent research, actually just published this month, shows that harm reduction, including naloxone and medications for opioid use disorder, are the most effective interventions that we can implement. In the short term, getting naloxone into people's hands, helping them prevent overdoses, then building trusting relationships through harm reduction and linkage to treatment, which then leads to medications for opioid use disorder. That array of services should also include counseling, peer supports, case management, and making sure we retain people in care. And these are, again, the science-driven, proven interventions that we can do to impact overdoses and substance use disorder. So I just want to leave you with the definition of addiction from the American Association of Addiction Medicine. It's a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. I just want to emphasize that as leaders in criminal justice, it's important for us to talk and think and focus on the treatable chronic medical disease part of that definition. So thank you.
Thank you. Does anyone have any questions or follow-up for Elise? Amy, for HHS?
I don't know where to stand, so go up here. Okay, so I'm gonna provide a little bit of history for our MOUD program, our meaning the county's MOUD program, the detention center. And then I'm gonna talk about the services that health offers embedded within the detention center. So a little bit of history. As you all know, there's a significant issue with substance use in the detention center with that population. So when we looked at this several years ago, prior to applying for the grant funding, the rate of opioid use disorder was estimated at approximately 30%. So we looked at data from medical screening intake. So prior to that time, MOUD was offered to individuals who are incarcerated at BCBC with the exception of pregnant women. But in consideration of that data and knowing that there was SAMHSA funding available, we partnered with the detention centers to apply for this funding, which we were then awarded. Slide. Thank you. Okay, so we were awarded a SAMHSA grant that was awarded in August of 2018, and the budget period for that was from 2018 to 2021. Shortly after, we were awarded a state opioid response grant for the same purpose. It was awarded in January of 2019. And so that grant funding continued through September of 2022. We had originally intended to grade the funding because of regulations and barriers that we encountered, which we didn't end up doing that. We had 2 programs, but it did enable us in partnership with the detention centers to begin a program to provide individuals with future. Okay, so as part of that grant funding, we were required to do data collection. And the data collection tool is, we affectionately call it the GPRA, the Government Performance and Results Act Client Outcomes Measurement Tool. It's completed at intake, so when people are admitted into the program, at that point they were incarcerated at BCDC, they were starting on buprenorphine. And it takes about 30 to 45 minutes to complete. Trained staff administer it. It's somewhat burdensome. It takes a lot of time. It's very invasive, but it did allow us to collect a lot of data. That tool was also administered at one follow-up point, generally after people had been released from the detention center. So it collected information like basic demographics, drug use, substance use disorder diagnosis and treatment, mental diagnosis, services received, living conditions, all of those things on that list. So we had access to a fairly robust set of data. Next slide. Okay, so we had evaluators engaged as part of this grant funding, and we were able to look at the results of those GPRAs. And what we found was that there were generally improvements in multiple areas. So mental health, from the FY20 and 21 evaluations, we found that from intake to follow-up, fewer program participants reported experiencing mental health symptoms, and their average quality of life improved. Adverse events, we saw that MOUD participants had fewer use of force incidents during their evaluation period than people who weren't enrolled in the MOUD program. And for this data collection and analysis, adverse events were defined as use of force by correctional officers or as attempted or completed suicides while incarcerated at BCDC. Recidivism, we found a fairly low recidivism rate among MOUD participants. It was 11% from FY19 to FY21. Self-rated quality of life. Respondents indicated that they had experienced a higher quality of life at follow-up, as indicated by their GPRA scores. The one area where we did notice that instead of going in the direction that we had hoped, our data indicated a different trend was in treatment recovery. So we saw that people who were incarcerated, who did that initial screening, were engaged in treatment at higher rates than people at follow-up in the community, which makes sense, you know, as we look at that as professionals, as people transition into the community from detention, there are a lot of competing factors. It's difficult for people to maintain that connection from incarceration to community. So that's what we saw in the data. So The importance of looking at this data, I think, one, that it indicates to us that our findings locally mirror what's in the literature, so what's happening nationally. I think it also is a way for us to understand that the benefits of allowing people to engage in MOUD treatment while they're incarcerated are large, and we've seen that from our population. So that instituting this program is not just a requirement of HB 116, but we can see how it benefits both the individuals and the program at large. Next slide. Okay, so transitioning to services that health offers currently within the detention center, we offer individual and group evidence-based counseling. So our counselors are trained in and utilize motivational interviewing. I think almost everybody's familiar with motivational interviewing, but that's an evidence-based practice that focuses on exploring and resolving ambivalence and centers on motivational processes within the individual that facilitate change. And I'm saying that deliberately because our approaches are designed to allow individuals to increase their self-determination, right? So we approach them in ways that allow them to determine what are my values, what's important to me, and we offer them the skills to then move toward accomplishing those things instead of imposing on them what we think they should do. Because we, as human beings, we know that generally doesn't work. Cognitive behavioral therapy, another evidence-based strategy, problem-oriented strategy that allows our staff to help people identify ways to solve the issues that they are facing or to cope with the issues that they are facing. And relapse prevention, a strategy that's inclusive of problem-solving approaches and techniques to identify and manage triggers for substance abuse. So again, we're approaching people in a way that allows them to increase their feeling that they are in control of the process. We also know that individuals who are incarcerated have a high rate of that. And these kinds of approaches are also really beneficial when working with those populations because they allow the locus of control to shift from the clinician to the participant. And that's really, really important as they move forward and identify things that they want to accomplish and develop the skills to do that. So we offer individual counseling. It's provided at the participant's request. Generally, people submit what's called a 118 form. You guys all know what that is. It's just a request form that comes to our staff. It says, I want to participate in the substance use disorder education group or whatever other group they would like to participate in. We offer counseling weekly, men's and women's substance use disorder education group, relapse prevention group. There are NA groups within the facility that our staff help to organize, but they don't facilitate because those are facilitated by any members who come into the facility. Okay, next slide. All right, peer recovery support services. Again, this is an evidence-based intervention and it's supportive rather than directive. So I'm preaching to the choir here. I think everybody's familiar with what peer recovery specialists do. One of the most important ways that peers benefit the people that they work with is by allowing them to identify and move toward the goals that they identify for themselves. So every peer, when they meet with someone, talks with them about establishing a wellness plan. So it doesn't necessarily mean you're going to enter treatment or you're going to establish abstinence. It means I'm going to help you identify the things that to you indicate that you are doing well. That may mean, regaining custody of children. That may mean finding housing. Whatever it is, our peers then work with those individuals to move toward the goals that they have identified for themselves. We know from looking at the research that peer recovery services increase self-esteem, self-efficacy, and self-management. They also reduce recidivism. So our peers go into the facility. We have 2 peers who are in the facility multiple days a week. They meet with people during their period of incarceration. They establish those connections, start to work with them on a wellness plan. And then when people are released, if they want, they can meet a peer. They can be provided transportation to treatment or to housing or whatever facility they identify as important for them. Our peers can help them connect with community resources. They can help them connect with treatment. Our peers can also help them to access recovery housing. We do have funding that allows individuals who are working with peers to have a period of time funded in recovery housing that helps people to stabilize and start to work on their recovery. We think it's really important and we really appreciate our partners at PCDC for letting our peers go into the facility and start these connections before people are released. Because as people walk out the door, as everybody knows, it's super chaotic. And if there's a familiar face waiting there, it can make all the difference. Right? It's the difference between walking out and seeing a stranger and walking out and seeing someone that you know and trust. That's important to you to continue to engage with. All right, next slide. Contingency management. So thinking back to the GIBRA results, right? Knowing that people, there's a decline in engagement in treatment from release, from incarceration to release. We found this opportunity and applied for funding to allow us to implement this program to start to address that. So this is evidence-based. What it allows us to do is to identify people who are on the MOUD program, who are being released into the community. We connect them with a case manager who helps them make that transition, helps them engage in treatment, and then they're offered awards at certain points in treatment. So if they are retained in treatment for 2 weeks, they receive an award. If they're retained in treatment for 4 weeks, they receive an award, also at 6 weeks. So we know that there's multiple other factors that impact a person's ability to remain in treatment, but the provision of these awards also helps to increase the likelihood that people are going to remain in treatment. The case manager is also a super important part of that intervention because she can help to identify those barriers that also may cause people to leave treatment. Slide. Okay, case management. So we currently have 2 case managers who are working with individuals at BCDC. We know that this is an evidence-based practice. This is a SAMHSA identified best practice. It reduces recidivism, it increases treatment engagement, and it increases engagement in employment and education services. So our case managers, we have 1 case manager who focuses on helping people who are on buprenorphine as they leave the facility to remain linked in treatment. So that includes identifying treatment providers, helping them make that linkage, and identifying resources in the community that will help support their recovery. We also have a case manager who focuses on everyone in the facility who is diagnosed with or at risk of substance use disorder. So she provides those same services but for a broader population base. Next slide. All right, we offer a trauma, addictions, mental health, and recovery group within the detention center. We call it TAMAR. It's staffed by 1 social worker, 1 case manager, and every year we have 2 interns from the University of Maryland School of Social Work. It's manualized and standardized, so we know that everybody in every group is receiving the same intervention over time. And it's designed for individuals with mental health conditions, substance use disorder, and history of physical and/or sexual abuse. Next slide. We also offer, we call it MCC-JTP, Maryland's Community Criminal Justice Treatment Program. This is a program that was established in partnership with the Maryland Department. And it focuses on helping people in the criminal justice system diagnosed with a serious mental illness and who are at risk of reinstitutionalization to link with services in the community that will help them avoid those results. We do have a case manager full-time employed with this program as well. Okay, so all of the services that I talked about all have naloxone training integrated into them. So when we do groups, our counselors do naloxone. When peers meet with people, they do naloxone training. Our case managers do naloxone training. We want to have everybody trained on naloxone who wants it, who will accept it. So our staff is training everyone who's incarcerated at the detention center that they can get their hands on. And then that naloxone is placed in their property. So when they walk out of the facility, they have that naloxone in hand if that's something that they want. We also now have a naloxone vending machine in the detention center lobby. So we're pretty excited about that. So if people don't get that naloxone when they walk out, if their family members want naloxone, they can access it through the machine. They don't have to input any information. It's free of cost. They can take as much as they want. So it's there, it's freely available. And that's our goal, is to have naloxone saturation throughout the community, to have everybody have it in their hands. Any questions? All right, thank you.
Thank you, Amy. Correction?
Good morning. We've got a lot of people from our BCDC team. Most of you guys know them. Mr. Tuku is going to kick off this presentation along with a few other people, but I'll let Mr. Tuku take it away.
Good morning, everyone. I think I'm just gonna go further into what Elise and Amy have discussed. We do know about the substance use disorder. If the participants in the community are not able to be compliant, then they end up at BCDC because of one or two things. Now, upon admission to the Baltimore County Detention Center, one of the things that we do is do a medical and mental health evaluation, which should be done within 4 hours. What we have done with that evaluation that is conducted is include a National Institute of Drug Use tool, which is a substance use disorder screening tool, which evaluates on the history of those individuals who are coming to us when they have been using alcohol, opiates, and benzos. Now, based on what they present, we are able to see how we can accommodate, how we can take care of them when we have them at the facility. For 2023, we had approximately 2,000 incarcerated individuals that were referred for substance use disorder evaluation. Now, like I mentioned, we have the NIDA tool, and how we refer these individuals is based on 3 parts. First part, if somebody is on alcohol or benzos, we don't usually treat them. We don't put them in a program. What we do is manage the withdrawal symptoms. So they get into a withdrawal pathway. There's withdrawal protocols that are carried out by a medical provider. Now, if they are on opiate use and they have hit a threshold, maybe it's based on what we are checking on the CWAS and COWS. CWAS is the Clinical Institute Withdrawal Assessment tool, and COWS is the Clinical Opiate Withdrawal Scale. Based on these 2 tools, we can define whether we're going to be treating you for the alcohol, we can be treating you for the opiates. If we are treating you for the opiates, there are 2 pathways. One of them that we are now doing, based on the grants that we have, we are able to refer you to the MAT program. And during the MAT program, they will induct you, continue you on medication that you had, or also continue doing counseling for you. The third one is what Amy mentioned. Maybe you were not caught during intake, because sometimes when people come in during intake, they don't want to be compliant. They think they are coming in and going out. So sometimes they decline. They say, I do not have any history of substance use disorder. I have no chronic problems. I'm fine. Just get me out of here. But they end up going to see the commissioner, and they're going to be sticking with that at BCDC. So when they realize they're going to be sticking, and maybe it's a few hours and they're starting to withdraw, there's the third option where they can use the Form 118 or the CICO slip to request some help. Excellent. Now, based on what they said, it's very important to realize that alcohol withdrawal, which kicks in within some few hours, is one of the most dangerous things that people can suffer from, especially when they do not have access to alcohol. So that's why I said within immediately, once you recognize that you have been using alcohol or you have some symptoms that based on this, on your CWAS score that deem appropriate for you to be treated, we start treating you immediately. Now, the protocol is like a 7 to 10 day treatment, which we're gonna be managed for your abdominal discomforts, tremors, sweat, all those discomforts that you can have. You'll be treated for that. Now, if you're in the category for opiates, we're gonna refer you. The medical provider, upon screening, refer somebody to our MAT provider. The MAT provider gets these people, they're gonna go call and see which programs they were in before. And if they were not in a program, they're gonna start looking into evaluating them and having them inducted. Currently at BCDC, we are in the MAT program, we are treating people using 2 medications. One, the methadone, and the other one, the buprenorphine. We don't usually use this sublocade, but if somebody came with it and they were doing it, we're gonna ensure that we get it for you, especially if the program was sponsoring. But usually it's methadone and buprenorphine. The other thing that we do during intake is also conduct urine screening, and that can be able to tell us what substances that you are using before. So we complete urine testing at intake, but also on a monthly ground, every 30 days, we do test our individuals to make sure that the medications are being used effectively, or if they are not being used, to make sure that there's nothing, no other contaminants that are present. Now, our MAT provider does medication management, whereby some individuals, once they stay in the program, 30 days, 60 days, might say, hey, the current dose that I'm on is not working for me. Could you please increase it? Or I don't want to continue. Maybe the medication management based on the dosage that they have is not making me feel good. Maybe it's not appropriate. Can I switch from one medication to the other? So these are options that our individuals get when they are there. Amy actually also mentioned about the NACAN kit education that is also offered by our MAT provider, which is MedMark, as you all know. So they do also offer that during the continuation of the program. And this more is the chronic care management of the substance use disorder. And I focused here more primarily on the medication protocol, which is the withdrawal management, the continuation of the medication, but we do also have the individual and group counseling, which I'm going to let Ms. Johnson talk about it. I'm sorry.
Go to left.
We did give some stats.
It's Leslie Frost. I'm the Baltimore County Detention Center MAP Program Manager. And I just wanted to give you a little history. I've been involved with the MAP program pretty much since it started in 2019. We started our own program in Baltimore County Detention Center on October the 1st, 2022, which was the go live date for HB 116, which is the governor mandated bill saying that anyone who comes into the program, into the facility, and wants either methadone or buprenorphine, they will be evaluated, and if they are eligible and screened above threshold, then it's provided. We're making our way to making sure that that happens. The numbers, when I was first working with it through the health department, we would average between 25 to 30 people on the program. And as of Friday, we were just shy of 200 people. So we've definitely grown. So when we started on October 1st, we did have an OTP, which is the on-site treatment provider, or opioid treatment provider. They were awarded the grant or the award on November of 2022. On February 14th of 2023, they began dosing methadone only through their transportation model, which meant the current medical provider was providing the buprenorphine, and the OTP was coming in with a transportation model under their OTP to treat new methadone patients. On June 13th of 2023, they were finally granted their final OTP license from the state and all the governing bodies, the EA, SAMHSA, all those had to get in line. They inspected the facility, made sure we had secure, that we had a medication vault, for lack of a better term. And then on July 1st of 2023, MedMark began dosing from the BCDC dispensary. They continued to medicate methadone, but then they started to bring on the buprenorphine patients. And you can see here, I just did a quick, this is as of 10/1/2022 when HB 116 first started. The numbers you can see in the date range for the buprenorphine, they really kind of skyrocketed in the 25 to 44 range for both men and women in both methadone and buprenorphine. Previously, I'd done a study on zip codes, and kind of leading on what Elise said, it really does impact that Bethlehem Steel, Essex, Middle River area, which I found that very interesting when we go to those economic impacts. So as of the date that this was reported on 2023, pretty much when I reported the date to the governor's office, we had 80% release plan average. But just to preface that, I was the only person on that team for quite some time, and I'm not mental health. I'm not here. So what I would do is meet with every person that came on, and the model at the time was if they came in on a program, then they would be guestos. So usually they had programs they could go to when they left. We've since hired a peer supervisor, and she's picking up everyone that comes in that didn't have a program, that needs a program, what kind of program they want. Do they want, you know, a living facility? Do they want just outpatient? She provides, sets up transportation with them. She's got relationships with a lot of the programs in the area. So I don't have the numbers for the rates yet because I haven't had it reported, but it's definitely increased, which is great news. And that includes, you know, if they want to go to Hope's Horizon, we'll pick them up, walk them out, hand them off to the driver. The driver will take them to usually a place that gets them some clothing, gift cards, anything they need, and then the driver will take them directly to the program. We also work a lot with Project Chesapeake, which is another big program. Anyone have any questions? Next slide.
Good morning, everyone. I'm going to cover the programs at BTD. So the following programs that we self-referral programs offer for substance use disorder are as follows. Narcotic Anonymous, the START program, which is Striving to Achieve Recovery Together. That program is a 6-week program. At the end, the young ladies do have a graduation at the facility. They're able to invite their children, family, and friends. TAMAR, which is Trauma, Addiction, Mental Health, and Recovery. They don't have a graduation where the family come in, but what they have is Miss Marilyn Mathias, who facilitates it. She provides them with pizza and sodas at the end of the program. We have substance use disorder group for men and women. The peer recovery support, they provide a release plan for the substance use disorder. They have additional co-occurrence support. With the MAT self-referral, we have, like Levitt mentioned, the MAT program. We have group and individual counseling for the incarcerated individuals at BCDC. We also have a peer recovery support. Leslie mentioned we do have the supervisor, but we will be conducting interviews for our own peer recovery specialists at the end of the month. And we have additional co-occurring support. Anyone have any questions? No, I'm going to turn it over to Captain Giza.
Morning. Some of the challenges with these programs are obviously the inmates are always striving to get their fix into building. MAT program, the biggest problem is diversion. Person on the MAT program will actually cheat the Suboxone, bring it back out and sell it to inmates in this housing which provides opportunity for more physical altercations because who's got the drugs, who doesn't have the drugs, makes staff and inmates obviously at risk. Of course, overtime for searches going into it, deep with canines, it creates a problem because we know some people on the program and they're just pushing off to somebody else. So trying to track down who actually has the original organization. The next slide. K9 unit started in 2020. Since then, as of 1st of April, we've stopped $1.3 million worth of CPS coming into facilities, which is 3 dogs. 145 court cases. Actually, as of today, it's 931 suspected confirmed fines. And the breakdown of obviously the drugs we have the most is obviously Suboxone, which is the biggest problem, mainly because it's subtext and it's easier to hide in male clothing and body parts.
Good morning. I'm Kiana Harris, Reentry Coordinator for the Detention Center. The reentry program is a voluntary program developed to address reentry related needs of incarcerated individuals. Individuals are referred via town hall meetings, which involves me going to housing units, introducing myself and the services provided by the reentry program, or self-referral, which involves individuals submitting a 118 form, which is an inmate request stating what reentry services are needed. We work with both pretrial and sentenced individuals. to develop reentry related resources and a plan. We also work with individuals who are interested in getting into a substance use disorder treatment program. Since individuals are enrolled in treatment prior to their release at their request, pretrial individuals are enrolled into an SUD treatment program prior to their next court date in hopes that the courts do agree to release them to a program. We collaborate with Healthcare Access Maryland to ensure individuals have Medicaid coverage prior to their release. HCAM is able to get them approved 30 days prior to their release, and approval takes about 1 day. When coordinating a warm handoff to treatment programs, that involves myself setting up transportation via the treatment program or peer recovery specialist. The reentry program also it also hosts, resource fairs inside the detention center for sentenced individual, which includes services that can assist in applying for social service benefits, workforce development, housing, and transportation. We also host reentry advisory council meetings monthly, which include stakeholders, including judges, the public defender's office, SUD and mental health programs, community resource providers, and information sharing sessions. Any questions?
Any other questions for any of the presenters? I have a question. For the drugs that are seized within the facility, are those cases investigated by the police?
Yes,
Or
we turn it over to the PD. Yeah, each gang unit helps us out. In fact,
what's the success rate of prosecution? Are they often?
I can, when we go to court, it should be fled into the other charges. Or there's always a consequence. It's not very, we have very little stat cases, so there's always some type of conviction.
Any other questions? Does anyone have the attendance sheet? Did anyone indicate they have a roundtable update for the group?
I did.
Go ahead.
I just wanted to say, I think the last time that this group met, the Baltimore County District Court, the Towson location, had unfortunately experienced a shooting at that location. I'm very pleased and thankful to Baltimore County Police. They did a fabulous job in being able to locate, capture, and bring into custody one of the individuals involved. And I bring those thanks not just on behalf of Baltimore County District Court, but on behalf of Chief Judge Morrissey, who has expressed his thanks to the fine work that Baltimore County Police did. It was quick. We were really not expecting that, but boy, hats off. Also, I wanted to just mention today, we will be having our first mental health court graduation. We have 2 participants who'll be graduating today. As you recall from Judge Davis's presentation, the mental health court is not the same as the incompetent to stand trial docket. This is a problem-solving court where the judges are specifically trained to do therapeutic support for those participants who are referred and agree to be a part of the program. So it takes a lot for those folks to reach the stage of being able to graduate. So we're absolutely thrilled, and we're going to have a big party today to celebrate them, their families, and others who'll be invited to witness the accomplishments that these folks have been able to make. So I'm thrilled to bring that news to you. Last thing I just wanted to mention, we are starting something called Schools in the Court. And this is a program where we are going to bring in high school students. We're going to launch our first Schools in the Court program over in our Catonsville District Court. We'll be involving 2 high schools that will be, I believe, 10th graders coming to the court to have a chance to see what the experience is like when sometimes people don't make the wisest decisions. So part of that program will involve a simulated traffic stop where drugs are found in the car and what happens to individuals when that occurs, as well as we are going to include the mobile crisis unit to talk about mental health, because we understand that Lots of our teams nowadays are really struggling, particularly after the pandemic and getting back into the school mode. They are really struggling with some mental health issues. So we have included that as a component. And we are very excited about this. A number of other jurisdictions have done this program, so we're thrilled to be able to start that program here in Baltimore County. So that's it.
Thank you. Anyone else?
Lauren, I didn't sign up to say that we had any updates because I wasn't sure how we're going to fit in time. So I just have a couple of things. First of all, Thursday, the Baltimore County Police will be officially celebrating our 150th anniversary. This is the department. We have activities planned at the Public Safety Building all day, starting at 10:30. There'll be lunch served around starting around noon. And we also have a ceremony, an official ceremony that will occur around 1 p.m. on Thursday. So we invite everyone out to that. I'd also like to thank the judge on behalf of our men and women of the police department. We take pride in making sure that we bring as many things to a speedy closure as far as like that case, but it also speaks to the benefit of this administration and the courts and everybody as partners investing in cameras. It's the fact that we have cameras, LPR, surveillance around not only Towson, but the entire community that helps us, to track down the suspects. It was pretty nice that we were able to bring up video footage. We actually had video footage and actual photo of the suspects hanging out our under shoes. And we had good vehicle description and everything. So once we had a vehicle description and a description of the two suspects, we were able to, follow that and follow other cameras in our efforts to identify them. And lastly, I would like Meg to give you guys an update on our legislative efforts this session, because we've been very successful in Baltimore County with a lot of legislation that we've submitted through the county executive's office.
Thank you, Chief. So we're very excited. There were two bills that the police chief asked the county executive to put forward in Annapolis that he did. One was on catalytic converters. I know everyone's familiar with the terrible problem we have with catalytic converter theft. Our detectives were able to identify a loophole in Maryland's regulation of pawn shop and precious metal second-hand dealers. We had automotive dismantlers that were doing like $1 million of business, just taking catalytic converters from anonymous people and then bringing in the licensed recyclers. You had licensed people getting into licensed people, but it was fencing. So the bill that has passed the General Assembly and we expect to be signed by the governor closes that loophole and will require those automotive dismantlers to record who brought it to them and the VIN number of the vehicle that it was from. If it's legit, if it's your mechanic taking it off your car, they'll have the VIN number. If they give a fake VIN number, that will give police something to investigate. So we think it will be a real breakthrough in being able to break up some of this just easy and very costly community fencing. We'll have to proceed to other states and surrounding states to really make this effective, to get other states to do the same thing, because otherwise people will just find another outlet. But we can get a very good improvement. The other bill we're very excited about will make the Glock switch illegal in Maryland. It's already illegal federally. It's a device that if you stick it on the back of a Glock handgun, or there's a version for an automatic rifle, it turns it from semi-automatic to fully automatic. And we're finding them at crime scenes. We're finding them used in crimes. The drive-by shooting that we had last year, time flies, was both a Glock switch on a handgun and on an AR. The bill was sponsored by Speaker Adrian Jones. So it has gone through the General Assembly, and we expect to be signed by the governor. It puts these devices in the same category under Maryland criminal law as the bump stock, which are the trigger activators. This is a different mechanism. So this will allow us to seek local prosecution.
You mentioned the boat bill also.
Yes, there were. We had asked for some things on abandoned boats, which is a particular problem on the east side. And Senator Elfreth in Anne Arundel County has succeeded in getting a bill passed that has some of the things we wanted. It will fix some of the antiquated requirements that were limiting our police officers in being able to effectively deal with boats, having to wait 180 days or 60 days before you could do something, because in Maryland law, these abandoned boats are treated like, jeweled treasures, even though somebody has scratched off the serial number and hidden it somewhere. So we're hopeful this will help us start to make a dent. There's some more things that we need, but it's progress, which is always happy thing to find and not to say.
And I'd like to personally thank you in front of everybody for all the work that you.
Thank you.
I always say, Meg's, she's one lawyer, but she's about 10 lawyers. I think her everywhere I go. It's like American Express. And lastly, we worked really hard this past year on the criminal justice, working with our legislative branch and with the county executive's office and everything, with things concerning our juveniles. We were successful in getting them to lower the age back to under 10 in terms of being able to charge individuals.
10, 12.
Well, 10 to 12, the charge of 10 to 12 was under 10 that they would not be charged. As cops, we think about who we can't charge. Believe it or not, some people would think we think about who you can charge. That's not true. But we were able to get them to lower the age and get them to add a few things. Once again, it's one of those things where we'll have to every year go back and we'll work on some things. We weren't successful in getting them to include threats of mass violence, which we see kids do, especially in school. We also were concerned about arson in second degree and malicious burning, which we know children engage in. But the thing that I was most disheartened about, and I presented to them, was, we should be really concerned about our youth and school violence. And one of the things they did not include was second degree assault. So I promised them that next year when we come back, we will make a case, and I will work with the school system. I will work with our state's attorney, Scott Schellenberger. We will document every incident of assault in schools in Baltimore County. We will present next year the fact that they need to, we should, if we're going to curb behavior, the thing kids do most is they fight. And that becomes, it graduates eventually to homicide if it's unchecked. And for us, it's almost irresponsible not to include that if we're truly, concerned about violence in our schools. So we look forward to next year.
Thanks, Chief and Meg. Just real quick, our next meeting is June 11th. We're going to continue the substance abuse topic, and we'll ask that the following groups present: the police department, drug treatment court, which Judge Wilson, correct me if I'm wrong, but that's a circuit court, specialty court, drug treatment court.
It is a district court, specialty court as well.
Oh, it is. Okay.
Yes. We have
Okay.
mental health and adult recovery, which is our drug
Okay.
treatment.
So we'll ask district court and circuit court, and I'll reach out to Judge Robinson.
And family recovery court, that's the circuit court program is the family recovery court program.
Is that focused on substance abuse? Yeah, then yes. Okay, yeah, that'd be great. Thank you.
There is also a circuit court drug court program. Judge Pecora has been handling that
That's
as well.
Two programs in circuit court.
Yes.
Okay.
Magistrate palliative versus the family recovery, one programs.
I think we would probably want the drug court,
Okay.
just for the sake of time. All of them? Okay, all right, so we'll do both of them. And then we would also ask the state's attorney's office and also the public defender just to present on their involvement in those courts. We just tailor it to your involvement to those three courts. And I'll reach out to Scott as well.
And Lauren, from the PD, what would you like to see?
Just any services that the police department offers. I think, prior to them reaching BCDC.
You want police presenting on the problem side?
Because I think we could do a better job of presenting you what we see.
Sure.
Is, you know,
Sure.
depend on everybody else to provide services, and we'll refer people to this,
Okay.
but we do more of the observation and enforcement.
That works.